Hello, my name is Marla Berg-Weger. I am the Program Director for the Geriatric Workforce Enhancement Program grant at the St. Louis University Family Center for Healthy Aging. Today, I would like to provide an overview for you of a dementia intervention called cognitive stimulation therapy, or CST for short. This is an intervention that we here at St. Louis University have been involved in since 2014, both providing this group intervention to older adults with mild to moderate dementia, but also providing training. I'll talk about both of those in more detail. This work is funded by the Department of Health and Human Services, Health Resources and Services Administration. This is a grant that enables us to support this work. Okay, CST. CST is a non-pharmacologic, evidence-based intervention for persons who are experiencing mild to moderate dementia. What exactly is this intervention? Let me provide a little bit about the background. CST began, as a good evidence-based intervention should, by doing a systematic review of the literature and an initial pilot study to determine the effectiveness. The founders, who are located in the United Kingdom, began with the concept that they would build on the existing therapies that were available at that time. And the time period was over 20 years ago. Reality orientation, reminiscence therapy, multisensory stimulation, and validation therapy were all interventions that were being offered during that time when, of course, there were no medications available. However, they were not necessarily all evidence-based. And there was a belief that with the fact that there were no medications that could stop or slow the symptoms at that time, that there needed to be something more substantial and more evidence-based. The idea of CST is based on the, as you can see here, use it or lose it concept, meaning the brain needs to be exercised and to be stimulated in order for knowledge and skill retention. This group intervention is offered twice per week, as I said, for persons who are experiencing mild to moderate dementia, and it can be offered in a variety of different settings. And the research has shown that it can be offered in a community-based setting, in a hospital setting, or in various kinds of residential care settings. The intervention, as you will hear me talk about in the next few slides, is based on various themes, which I'll talk about. It could be something from food. It could be childhood. It's the idea that you bring things from the past into the present. The key aims of CST are to improve cognitive functioning, but also using techniques that exercise and stimulate different kinds of cognitive functions and skills. So specific target functions are executive functioning tasks. An example of that would be categorizing objects or words. Multisensory stimulation, which can come from hearing, seeing, smelling even. And then finally, reminiscence. Again, bringing things from those long-term memories, which we know are retained longer than short-term memories for someone experiencing cognitive impairment. How did it come about? Well, as I've mentioned, it was developed by a group of faculty researchers in the United Kingdom in the 1990s who were interested in developing more non-pharmacologic approaches to dementia care. Woods and Orrell began this journey by writing an editorial in 1996 looking at the medication that was available at that time, Tacrin, as well as comparing that to psychological therapies in dementia. Their conclusion was that psychological therapies should be considered as serious competitors to drugs, but there weren't any that had evidence to support that. Also, the studies that were available at that time were not as methodologically sound. The instruments that were available to measure evaluating and the outcomes of various studies didn't compare to the drug trials, and that there had not previously been funding available for large-scale non-pharmacologic studies that could look not only at outcomes but cost and benefits. So funding was secured by the founders of this intervention, and they began the course of developing CST as we know it today. Who benefits from CST? Well, the studies over these last 20 plus years across multiple countries, multiple kinds of groups, and in multiple kinds of settings have shown that the higher the cognition in the reserve of the brain enables a person with that categorization to be able to respond better to CST. Persons who are older, more than 80 years, tend to benefit the most. Females also seem to have better outcomes. And then finally, persons who are at the same time that they're participating in CST are also on one of the dementia medications. And as we know, those have improved greatly since the intervention was founded over 20 years ago. Long-term benefits. And I will talk a little bit more in the next couple of slides about the actual process and the original sessions that happen twice a week. But I want to mention so that you have this context, there are significant long-term benefits, and that is referred to as maintenance CST, which continues after those twice weekly sessions for 7 weeks. The research on this shows that when it was evaluated and compared across different groups, as you can see here, that maintenance CST improved quality of life at 3 months post-group participation and again at 6 months. And activities of daily living were also shown to maintain their improved state at 3 months. Cognition was higher in those members who participated in an ongoing basis in maintenance CST or MCST. So the conclusion was that MCST did appear to be effective regardless of whether or not there was a medication that was being taken at that time for cognitive impairment. However, the greatest improvements were seen in the medication plus maintenance CST groups. Conclusion? There's good evidence to show that continuing CST beyond the initial 14 sessions can certainly be helpful as long as the person is still willing and able to participate. I'd like to talk now about the key features of the program. I've mentioned several times there are twice weekly sessions for 7 weeks for a total of 14 sessions. These sessions are approximately 1 hour in length and include ideally 5 to 8 persons with 2 facilitators. It can certainly be done with 1, but 2 is recommended. Each session has a set curriculum, which the facilitators can be creative and in the way that they're facilitated for the members in the group. So choice of activities, and those can be adapted to cater to the interest and the cognitive and physical abilities of the members of the group. The research has shown that it really is most effective and meaningful, impactful for members of the group to be at similar stages in their cognitive impairment. So possibly all could be maybe early stage or mild cognitive impairment, or maybe the group should be more progressed. Granted, that's a challenging thing to accomplish in all settings, but the outcomes are better if people are at similar stages. And then attention should also be paid to gender mix. Ideally, great to have a mix of genders, but the issues are also just as relevant and the outcomes are positive if they are single gender groups as well. Who is appropriate to be included in a CST group? Does the person meet mild to moderate criteria for dementia? Yes, they are appropriate. Is the person able to have a meaningful conversation? Can they engage over the course of an hour? We know that sensory impairments are commonplace among us as we age. However, for meaningful participation, can the person hear and see well enough to be able to have participation in the group discussion, both for hearing and vision? And is the person able to remain focused and in their seat for the majority, if not all of the session? And as many interventions for all ages did during the pandemic, CST transitioned to virtual in many locations, including St. Louis University. So that creates yet another criteria. Does the person have access to smartphone, a tablet, a computer? Do they have internet access? Can they access and engage in a virtual environment, and even if they need help? So those are all things to be considered for membership in CST. I want to make a comment here. Many of you are familiar with the Age-Friendly Health Systems Framework, which includes the 4 M's. You can see here on the slide, the 4 M's include what matters to the individual and their family members in terms of quality of life, advanced care planning, daily living. What about medications? Are there medications that are contraindicated for someone who's experiencing dementia? Does it worsen the dementia, for instance? So there need to be not only thoughts about contraindications of medications, but also, are there co-occurring conditions that can also be treated that would improve the person's ability to engage? Mobility. Is the person able to get to a group, even if that means a physical transfer, or just even engaging in a virtual group by sitting in front of a computer? Mobility also speaks not only to physical mobility, but it also speaks to the ability of someone to get to the places that they would like to go and need to go. And finally, mentation, which is the one that relates obviously to the CST intervention. Mentation includes dementia, depression, and anxiety, and all of which have the potential, dementia certainly, but depression and anxiety can also impact cognitive impairment. So it's important that we think about what options are available to address mentation in terms and in context of what matters to the individual. So those are all things we need to be keeping in mind as we're thinking about offering this intervention, referring people for this intervention, or just supporting a family member to participate. Let me share now a little bit about the session structure, and that will give you a sense of what the typical kind of group session would look like. So the facilitators welcome each member individually, and they may even have name tags that are put on each time, just as good reminders. The ritualistic aspect of this helps to orient members to the beginning of the group and to the other members, but it also fosters a kind of ongoing rapport among the members. Every group chooses their own name, and this becomes, that happens on the first session, and this becomes a part of the opening introduction to the group. So facilitators state the name. It was chosen by the group members, giving them this sense of ownership and connection to these people and this group. There's, as you can see here, there's a softball toss. Typically, that's that multi-sensory stimulation that I mentioned earlier. This serves as a warm-up and, again, kind of an orienting kind of experience. It kind of keeps people alert, and it's also a tool for the facilitators to gauge the language, how the person is doing in that day. So as the ball is tossed, there's a question that comes with that, like, how are you feeling today? Was the weather like when you came in today? So that enables the individuals to get themselves oriented to what's happening in the moment, but also then to plan and tapping into their executive function skills, plan for their next step. They have to catch the ball, they have to answer the question, and then they have to toss the ball to the next person. So the final part of the introductory activities for each group session is reference to day, weather, and season. You can have these on a board so the members can see this when they come in. Remember that one of the things that's important about CST is the implicit orientation and the implicit questions that are asked. Members are never asked to state facts or statistics or numbers. They are asked to share their thoughts, their views, their opinions. So this is a way, by making reference to the day, the weather, and how people are feeling. Even, it's spring out today. How does that make you feel? Notice that emphasis not on asking what season it is, but on what the feelings are about the season. Each group also selects a theme song, and this is typically sung at the beginning and can also be sung at the end of every session. It's always important to have either the words or, as you can see here, the actual music available. So it can be on paper that they follow along, it can be up on a screen, but it's important. This, again, is an activity that bonds the group together. It needs to be a song that's familiar to people from the past, typically. And it needs to be a song that is relevant for the group members. And it needs to be short, and sometimes only the chorus is sung each week. The next part of the activity is current affairs. And this is where the facilitators will identify an article that's in the news at the general time of the group. You can see there's an example from the New York Times. It can come from any news outlet. It can also be a human interest story. It could be controversial, political in some respects. And the reason that controversial topics are important is that as people progress into cognitive impairment or dementia, others stop talking to them sometimes, stop asking them for their opinions or engaging them in controversial topics. So we know from the research and anecdotal experience that people with dementia still have thoughts about current events and have opinions about politics and other social issues. So this is an opportunity and a venue to be able to offer that. It also can help you to continue the orientation process to day and date of the paper. It's important that you, again, have this in print form, or maybe a summary of the article, or have it up on a screen so that people can follow along as well. Next activity as part of the 1-hour session is what's referred to as the main activity. Here are the 14 session topics. They are typically done kind of in order, although here I've organized them by more physical activities as opposed to creative activities. There is a manual. I showed a picture of it earlier, that it's called Making a Difference. And the manual actually lays out activities for each of the 14 sessions, along with any supplies or extra things that you might need. The activities are presented as both level A, which is more complex, and B, which is a simpler version of the same activity. They can be enhanced by integrating music, sensory stimulation, bringing, baking cookies or bringing in freshly baked goods that generate an aroma for people to react to and reminisce about. And you can see here, the topics cover a wide range, everything from childhood to number games, word games. But again, remember, it's not about trying to have the members specify specific numbers, for instance, or specific words, but again, getting at the thoughts and the feelings. And if the facts come, that's great, but that's not the main goal. And finally, we're at the end of each session, and here's some suggested activities for closing out the group as well as homework, if you will. So closing out the group, talk about the time, day, and activity for the next session, and ask members to share their opinions about the group session. What did you like about today? What kind of things would you like to do in the future? And then suggested activities for home could include sending a handout or a copy of a news article that was read at the beginning of the session, or another one that maybe they could talk with family members or caregivers when they're not in the group. And that's an overview of one session. So for the last few minutes here, let's look at why do we think CST works? Well, back to that comment that I made earlier about the use it or lose it approach. We know that what CST does is by taking part in mentally stimulating activities, this strengthens and even creates new neural connections for people. Thus, the improvement in cognitive function on pre and post testing. Also, CST provides complexity, novelty, and diversity of activities, ideas, thoughts, and brain function, so that those cognitive gains can actually be transferable to other parts of their life. Lastly, the positive reinforcement of questioning, thinking about, and interacting with objects and people are also very stimulating. The social environment is very positive and stimulating. And then lastly, the quality of life that one experiences on a day-to-day basis is actually something that as your quality of life improves, so does your cognition, and vice versa. As your cognition improves, so does your quality of life. And both of those things, we encourage anyone who offers CST to include those as pre-assessment measures as well as post, so that you can compare. Common goals and objectives of each session. We've talked about these, but just to recap: orientation to time, place, and person, increased attention and concentration, both, encouraging language to be more expressive. Oftentimes, as one develops a progressive cognitive impairment, they become less expressive because they're beginning to lose access to words. And this helps to exercise those word finding skills. Increasing active engagement and confidence. As people are engaging in meaningful interactions, they feel better about themselves and they become more confident to share those thoughts and feelings and opinions. Mood is elevated. We also use that in our own pre and post. Promotes social awareness, the activities, what other people are talking about, the current affair, of course, promotes new ideas and helps people to make those associations. And new learning can and does, in fact, occur within the CST experience. I'd like now to show you an example of one of the main activities that is part of the CST group experience. This is called Famous Faces, and it can be also scenes. It doesn't have to be people. You can see here, these are two people that most everyone would know. And it's not important that the members of the group know that this is Barack Obama and George W. Bush, who were former presidents. That's not what's important. What's important is that they react to this. And if people know who they are, that's great. You can have that conversation as well. But the facilitator, for instance, might ask, who do you think is friendlier looking or more attractive? Do these two have anything in common? But how are they different? And this really can stimulate great conversation. I've seen some wonderful experiences through that. And it does help people to bring those memories of who these two, in this case, men are, bring those memories of them, positive as well as negative. One of the great questions that gets asked in this is, which of these would you like to have lunch with? So this is just one example of ways to engage people to promote cognitive stimulation. Just quickly, I want to share, we have been doing research in this area since 2015, and I won't spend time on this slide necessarily to look at all of the statistics here, but what I want to show you is the bar chart at the top. So these are our pre and post test. So the St. Louis University Mental Status Exam measures cognitive stimulation, is on the far left here, and you can see the average score before participation in CST was 13.93 out of a score of 30. It was raised almost 3 points up to 16.35. The next one is the Cornell scale for depression with dementia, and you want that one to go down. So you can see pre, it was the mean score was 4.65, decreases to 2.46. So less depression. And then finally, quality of life for people with dementia, mean score before participation was 35.4, goes up to 38.15. So these are all exceptional findings. This is not in any way, I want to emphasize, not considered a cure for dementia, but it is can be a fairly long-term kind of experience for people where they are continue to realize improvements in each of these areas. We're all familiar, I think, with the clock drawing test, and this is an interesting part of a cognitive assessment because it really is looking for the functionality of the person's executive functioning. Executive functioning requires planning and knowing what the next steps are, just like driving. You have to be anticipating multiple things and sequentially what's going to happen next. So let's look at these clocks. On the left-hand side of the screen, you see a clock that was drawn pre and post. And you can see that the one on the far left is not an appropriate analog clock, but look at the one on the right under figure 1. Very, very much correct. The person was given the instruction in both of these cases to draw a clock, include the numbers, and show the time as 10 minutes to 11. So the clock on the right, again, maybe not quite the dramatic improvement that we saw in figure 1, but certainly a significant improvement back to nearly accurate. So these are just some points of evidence for the value of having an intervention like this. We have also here in the US added exercise to CST, and our research findings are showing that mobility, ambulation improve when people are participating in activities, and typically they're chair-based activities. Could be chair exercises, chair yoga are two of the examples, but it shows that there's, and we know this, the research has been showing this to us for years, that being physically active and engaging in exercise on a regular basis does improve our cognition and kind of vice versa. So this is, in our estimation, a win-win for everyone involved. And it's an enjoyable group bonding kind of activity. And it may provide an opportunity for people who are not able or in a position to exercise outside of the groups. I want to show you one more activity. This is from session 9 of 14. It's called Categorizing Objects. And this is one where they take these take objects of, it could be photographs, it could be blocks, as you see here in the example. And they could do just a very simple categorization by putting all the same shapes together, or they could be asked to do something more complex at the higher level where they have to group them by categories. So in this case, using the example here, they have to put all the circles together, all the triangles together, and then compare and contrast those. But these activities may seem simplistic. However, they are tapping into all of those things that I talked about that we know make CST a viable alternative. I have some resources here for you. We have partners across the state of Missouri and beyond. CST is currently being offered in over 30 countries, and in many of those countries, there's ongoing research, just as there is here with us in the U.S. For more questions, please feel free to email us at cst@health.slu.edu. If you have other questions related to the work that we do, here's another email, memoryclinic@health.slu.edu. Over on the right-hand side of the screen, you will see a QR code. If you would scan that and complete for the evaluation so that we know that you have viewed this video. And at the bottom, I want to talk about CST training. I mentioned early that we not only offer groups through our Family Center for Healthy Aging, but we also provide training twice annually. We provide training for people who want to be CST practitioners and facilitate groups. We offer a virtual training in October and a June training in a hybrid format as part of our summer conference. And then we also provide training for trainers, and we offer this annually, typically in the spring, but it can move around depending on the demand for it. And we are working currently on a manual as an American adaptation. As I've mentioned, the original manual and intervention were developed in the UK. So please don't hesitate to reach out. This is an intervention that has significant promise, and we would love to hear about more people engaging in it. Thank you.